Welcome to AETCM, the emergency medicine channel. Today, let us discuss about narrow complex tachyarrhythmias. As part of ECG learning, we have already learned how to analyze the rate in ECG, rhythm in ECG. Today, we are going to learn about narrow complex tachycardias. So, we have already discussed what is narrow complex. When the QRS complex, when it is SA node to AV node conduction, then AV node to bundle of his conduction, the P wave to PR interval, QRS forms here. Okay, normally it is less than 3 small squares in ECG. If that is within the range, you call it as narrow complex. If that is above the range, something like this, it is wide complex. So, we are going to talk about narrow complex tachycardia. What you should understand is narrow complex means the rhythm is originated above the ventricle. If wide complex, sometimes the rhythm abnormality can be in the ventricle or there is a conduction defect in the conduction system. So, normally when we run or when we are frightened, when we have fever, you have tachycardia. That is called as sinus tachycardia. Sinus tachycardia means you are seeing a P wave, you are seeing a PR interval, then you are seeing a QRS complex. Only thing is the rate of the heart is very high, more than 100 beats per minute. Okay. So, to calculate the rate, you have to see the QRS complex, 2 QRS complex. In between the numbers of large square, you have to see if 3 large squares are coming, 300 by 3, it is 100. So, that is the way you calculate the rate. If the heart rate is not very high and is somewhere around 100 to 120, then you can call it as sinus tachycardia. It can be due to fever, it can be due to hyperthyroidism, it can be due to exercise, anxiety, fear, all these things. But this is a narrow complex QRS complex. Since it is a normal sinus rhythm, it is a narrow complex. Now, if the heart rate is slightly higher than the normal expected rates, maybe more than 140 to 140, and still it is narrow complex, you can call it as a SVT. But if it is wide, then it can be SVT with aberrancy, RBVB, LBVB, or WPW syndrome, like that. So, narrow complex means there is no problem in the conduction system, but it is faster than the usual rates. There are 3 important types. One is AV nodal re-entry tachycardia. Inside the node, it is the current is recirculating. AV re-entry tachycardia, that means in between atria and ventricle, the re-entry happens. Non-re-entry tachycardia, there is no re-entry, but multiple foci is producing current. There is multifocal atrial tachycardia. It is something like atrial fibrillation, whereas in atrial fibrillation the rate is very high. The atrial rate may be around 600 beats per minute, atrial rate. Ventricular rate may be around 140 to 240. Whereas in multifocal atrial tachycardia, the atrium is stimulated from different focus, not from the SA node alone. Okay, it is from the different focus, and that produces tachycardia. Now, calculation of rate we have already seen, 300 by number of large squares will give you the rate. Now, when you are seeing a narrow complex rhythm, you have to always see whether it is a tachycardia or not. That is the first thing you have to see. Then you see the tachycardia is narrow or wide. Okay. So, less than 3 small squares, it is narrow complex. Then you see whether the QRS complex are coming regularly or totally irregular. Totally irregular. So, that is a next thing you will see. Third one is it a sudden onset or a slowly progressive? Onset, okay, that is paroxysmal supraventricular tachycardia is sudden onset and suddenly patient may recover also. Then look at the P wave. If P waves are present, then it is in the QRS complex or after the QRS complex, whether it is inverted QRS complex, all these things you have to see. So, the most important thing is look at the P wave. Sometimes P waves will be embedded inside the QRS complex, you may not see at all. So, AV nodal re-entry tachycardia means SA node to AV node, the current will transmit like this. AV node, it has to go to the ventricle, but sometimes what happens, the current will recirculate inside. And every time it will, when it recirculates, every time that also send a signal to ventricle. The ventricle rate will increase to 140 to 200. So, that is called as AV nodal re-entry tachycardia. So, normal PQRS can be seen in first one, normal this one, but whereas in AV NRT, you are not seeing any P wave, you are getting QRS complex, they are regular, narrow, but it is rapid. P waves are hidden inside the QRS complex. You don't see P wave because it is not originated from the SA node or from the atria. If it is originated from the atria only, you can see all these things. Here it is inside the QRS complex, so there is no proper P waves formed. Even we don't know whether it is formed or not, but it is inside the QRS complex because both atrium and ventricle simulated together. Associated with fast AV nodal pathway for anti-grade conduction and a slow AV nodal pathway for retrograde conduction. Retrograde P waves or negative P waves appears after the corresponding QRS. That means normally when the conduction happens like this, you are not seeing P wave, but sometimes when it goes like this, you can get QRS complex and you may get a small P wave after the QRS complex. That is not very usual. So, we don't read this slide at all. For a usual MBBS or postgraduate learning, this is not very useful. But a cardiologist, this type of findings may be very useful. So, we don't discuss this type of things in our class because we are going to treat these patients tachyarrhythmia only. We are not going to make a complete diagnosis from the ECG. AV re-entry tachycardia is another problem. AV re-entry tachycardia is, you can see the heart here. Now, previously what we have discussed is the re-entry inside the AV node. But here the re-entry occurs, this is SA node, from normal it has to go like this. But due to some reason, there is an accessory pathway. Through this accessory pathway, it may go in this direction or sometimes it may go back in this direction. So both things can happen. That is, if this goes in this direction, this is called as orthodromic AVRT. That is different from the previous thing we have discussed. This is orthodromic AVRT and antidromic is on the opposite side. Okay. So, this is AV re-entry tachycardia. One of the important condition we should remember is Wolff-Parkinson-White syndrome. That is an accessory pathway condition. So, here you get bundle of Kent accessory pathway. That if the conduction is antidromic conduction, then you get a wide QRS complex. P waves are rarely seen. P waves are seen, then it may be retrograde conduction, but there is a typical pattern of the QRS complex. You are not seeing P wave, but the QRS complex is wide. There is a slurred upslope of the QRS complex. Here you don't see that slurring upslope, that is called as delta wave. So, retrograde P wave is also seen in this ECG. Whatever it may be, this is called as WPW syndrome. This is AV re-entry tachycardia. This is through a faster pathway. That pathway is called as bundle of Kent. So, we have to think about AV re-entry tachycardia with orthodromic conduction and antidromic conduction. How the ECG is different. First we will see the orthodromic conduction. The rate is very high, both conditions, it is 200 to 300. P waves may be buried inside the QRS complex. We have seen that in previous slide. QRS complex is usually narrow unless we block the pre-existing bundle block. You cannot see a wide QRS complex. And you can see alternate large and small QRS complex. T-wave inversions are common. ST segment depression also seen. Whereas in antidromic conduction, rate is very high. Wide QRS complex, that is very important. Wide QRS complex is a feature of antidromic conduction. Now, why we are telling all these things? When we have a narrow complex tachycardia, we have learned that it is SVT. But when we have a wide QRS complex, it can be SVT with RBVB, SVT with LBVB, SVT with Wolff-Parkinson-White syndrome, or ventricular tachycardia. So, this is the problem. So, wide complex tachycardia, when you are seeing in ECG, it can be anything. It can be SVT with aberrancy, that is RBVB, LBVB, or Wolff-Parkinson-White syndrome, or it can be VT. Now, tachycardia, wide complex, regular rhythm. So, you can see here there is tachycardia because you are seeing nearly 1.5 squares, 300 by 1.5 means it may be very high, around 200 and 225 may be the rate. The QRS complex is very wide, maybe 4 squares, so it is wide and they are narrow. So, what are the possibilities we learned? It can be SVT or VT. SVT means it can be LBVB, SVT with LBVB, SVT with RBVB, or WP-W syndrome, or it can be VT. So, we are not bothered about actual diagnosis because according to the ACLS protocol, wide complex tachycardia, the treatment algorithm is same for all. Whether you have SVT with aberrancy or VT, the treatment algorithm is always similar. But whereas in SVT, narrow complex tachycardia, the treatment protocol is different. But if you know about SVT with aberrancy, then you can use same treatment what is given for narrow complex tachycardia. That is the advantage. As a whole, the narrow complex tachycardia treatment is different, wide complex tachycardia treatment is different. But if you know that this is wide complex tachycardia with RBVB, you can use the same treatment given for your SVT. If it is RBVB or LBV also, you can give the same treatment. If it is some types of WP-W syndrome, also you can give the SVT treatment. But in VT, the treatment is entirely different. But whatever it is, if you have a wide complex tachycardia, your treatment goes according to ACLS, it goes in a different direction. Narrow complex tachycardia treatment goes in a different direction. But if you know the ECG properly, then you can mix up the treatment. Tachycardia, narrow complex regular rhythm. So, previously we have seen tachycardia, wide complex regular rhythm. Here tachycardia is there, the QRS complex is narrow and it is regular. So, tachycardia, narrow complex regular rhythm is the diagnosis here. So, no need to make the proper diagnosis, proper ECG diagnosis. According to ACLS, you have to tell whether it is narrow complex or wide complex, regular, irregular, hemodynamically stable or unstable. See, these are three things you have to see. So, here the another important type of rhythm abnormality, there is atrial fibrillation. Normally SN node to AV node you get only one conduction like this, but here what is happening, multiple foci are there in the atrium, they all start firing the electrical current to the AV node. So, there will be large number of P waves like this, and some of the P waves may transmit to the ventricle and you get a QRS complex. Large number of P waves, then one QRS complex. Large number of P waves, then QRS complex. So, what is the important finding you are seeing here? The RR interval. The RR interval is varying. Okay. So what is the diagnosis? It's a narrow complex, it's irregular rhythm. Then the third thing is very, very important, whether the patient is stable or unstable. Now this is atrial fibrillation. Instead of telling atrial fibrillation, you have to tell the tachycardia is there, heart rate is very high. You can use the 6-second method what we have learned previously. There is tachycardia. There is a first thing. Is it regular or irregular? That we'll tell afterwards. Is it narrow or wide? It is narrow. Is it regular or irregular? It is irregular. So three things: tachycardia, narrow complex, irregular. So irregular, narrow complex tachycardia. The next question will be whether the patient is hemodynamically stable or unstable. Okay, stable or unstable, that is very important. So here what you are seeing is heart rate is not very high, but heart rate is not very high, QRS complex is narrow, but the RR interval is not equal. They are irregular. So atrial fibrillation is there, but what is the problem? It is controlled. The rate is controlled with drugs like beta blocker, diltiazem, verapamil, digoxin, amiodarone, whatever it is. So any drug can control the rate. So it's a AF with controlled ventricular rate. Actually, whenever we have a tachycardia in emergency room, our responsibility or our duty is to control the rate. Most of the time, we may not achieve the rhythm control. We will be able to control the rate, because if the heart is beating very fast in a rate of 140, 160, 200, the diastolic phase will come down, the pumping can actually reduce. So to avoid that, our duty is to control the rate. That is the most important step in emergency room, whether it is SVT with narrow complex, SVT with the wide complex, or atrial fibrillation, VT, whatever it may be, control the rate, the symptom will improve. AF with controlled rate, the both are AF with controlled rate, but the problem is here RR intervals are not equal. This is small, this is large, this is large, this is large, this is large, this is small, this is also small. So RR interval are unequal, but rate is controlled. Whereas this heart rate is very slow, but RR interval is equal. That is because this rhythm is originated from the ventricle. This is due to complete AV block. So atrium beats in its own rhythm, that is very fast, but ventricle also beats in its own rhythm. There is no association between atrium and ventricle. This may be due to digoxin toxicity, where the patient is on digoxin, or due to a conduction defect. Patient may be old, a degenerative heart disease. On top of that, patient might have had atrial fibrillation. We don't know what is the condition. Now atrial flutter, after sometimes atrial fibrillation, you get a sawtooth appearance like this. That is atrial flutter. Okay. So atrial flutter is slightly similar to atrial fibrillation, but RR intervals are mostly equal. So here it is atrial flutter. You can get the sawtooth appearance here. QRS complex. Again 4 or 5 equal P waves like sawtooth. Then QRS complex. Now what you are seeing here is, first one is atrial flutter, then 2:1 AV block, some areas. So 2 atrial beats, then 1 QRS complex, 2 atrial beats, 1 QRS. Here it is 4:1 AV block. The type of flutter. Third one is atrial flutter 4:1. Next is 3:1, 2:1. Different types of blocks you are seeing in atrial flutter. That's all. Multifocal atrial tachycardia means more than 3 different morphologies of P waves in your rhythm strip. You can make a diagnosis of multifocal atrial tachycardia. I will tell you why it is happening. Normally SA node to AB node, one conduction happens. So you get a similar type of P wave. the same P wave. But just see here, this is your atrium, your ventricle, SA node to AV node conduction happens like this. This P wave will be like this. Suppose another area current is coming. This P wave will be slightly towards this side. Another P wave is coming, next P wave is coming from this side. So this is slightly like this. If this is originating from here and retrogradely conducting, this is P wave is like this. So if you see the tracing, then it will be like this. First P wave is normal, QRS complex. Next one is like this, QRS complex. Next one is like this, QRS complex. Next one is sometimes P wave comes before QRS complex, sometimes after QRS complex also it can come. So this is called as multifocal atrial tachycardia. This is classically seen in hypoxic condition like pulmonary embolism, COPD with acute exacerbation, asthma, ILD, all these things. This is a very common arrhythmia you see, multifocal atrial tachycardia. If the rate is low, you can call it as wandering pacemaker. If the rate is very high, you can call it as multifocal atrial tachycardia. Whatever it may be, your questions are same. Whether it is tachycardia is there or not, that is the first question. Is it sinus tachycardia or any other type of tachycardia? That is the second thing. Next, you see at the QRS complex, they are narrow or not, narrow or wide. Then you have to ask whether they are coming regularly or irregularly. Last question is very, very important, if they are hemodynamically stable or not. If they are not hemodynamically stable, then you have to go for cardioversion. That is very, very important. If they are hemodynamically stable, hemodynamically unstable, you have to go to cardioversion. If they are hemodynamically stable, then if it is SVT, you can try adenosine, vagal maneuvers, beta blockers, diltiazem, verapamil, all these things. If they are irregular, atrial fibrillation is there, then no need to go for adenosine, no need to go for vagal maneuvers, you can go for beta blockers and calcium channel blockers. If you don't know what is a type of arrhythmia, and if it is wide complex tachycardia, then you can go for amiodarone infusion. So antiarrhythmic infusion is amiodarone, that can be tried. So that is very important. Amiodarone is one of the most useful drug among all these categories because the adverse effects are very less. It cannot produce hypertension. If you are not able to understand anything, even if the BP is slightly low, whether it is narrow complex tachycardia or wide complex tachycardia, you can still go to amiodarone. But according to ACLS protocol, this is not correct. Whatever protocol is there in ACLS is like something like this. So if the narrow complex tachycardia, you have to try all these things. If that all fails, then you go for amiodarone. Unnecessarily, we should not go for amiodarone. But if you don't know anything, you start amiodarone, also patient improves and side effects are very less. And we have discussed about one of the most common problem in emergency room, that is acute tachyarrhythmias. When the patient comes, you have to see whether there is tachycardia or sinus tachycardia, supraventricular tachycardia or sinus tachycardia. Supraventricular tachycardia, most of the time heart rate is very, very high, 140 to 200. When the heart rate increases, diastolic phase come down and that affects your pumping. Patient can go to hypertension shock if you don't treat properly. Then look at the QRS complex, whether they are narrow or wide. Then second thing is you have to see whether they are regular, irregular. Narrow complex, regular is always supraventricular tachycardia. Narrow complex, irregular is atrial fibrillation. Wide complex can be SVT with aberrancy, SVT with WPW syndrome or VT. If the patient is hemodynamically stable, you can try drugs. If patient is not hemodynamically unstable, you go for shock, cardioversion. Wide complex tachycardia, you can go for amiodarone. Narrow complex tachycardia, you can go for adenosine, you can go for vagal maneuver, you can go for beta blockers, you can go for calcium channel blockers. If that doesn't work, you go for amiodarone. Digoxin was used previously for all types of atrial fibrillation and reduced cardiac output. Also, we used to give digoxin. Nowadays, the only indication for digoxin is atrial fibrillation with cardiac failure. That is because of the adverse effects of digoxin, not because that is not useful in the conditions where cardiac failure is there. It is only because of the adverse effect of the digoxin, or sometimes it itself will produce a lot of arrhythmias. Thank you.